second slide, please. I'm hoping that after this hour together that we will be able to describe what motivational interviewing is, identifying the 4 key MI skills, and understanding just some basic kind of strategies that will help enhance patient readiness to change and demonstrating use of our basic MI skills. So that is my hope. And it's like Elsa or Amy, it looks like we're stuck on the slide that sort of is like the beginning before you actually get into the slideshow.
All right. Thank you for letting me know. Sometimes Zoom shares the wrong screen.
I know. No worries.
All right. We will do it again.
Perfect. Thank you so much. So these are the learning objectives, and I guess I should back up and let you know before that, before we jump in, that I'm currently working clinically at the Women's Integrated Services and Health Clinic at Anschutz campus. So it's a women's clinic in the hospital. I'm the primary psychologist there, and just doing some integrated healthcare. But and so I'll give you some examples of how I'm using motivational interviewing clinically every day, and hopefully they will be relevant to you in your practice as well. So go ahead and advance a slide, please. So what is motivational interviewing? I think the first thing that's most important for people to know is that it started out as a therapeutic modality specifically for addictions treatment. And that was about 35 years ago. And in those 35 years, it has blossomed significantly, and it has become so much more than just a therapeutic modality. It's actually just a really great communication style. And so go ahead and advance, please. So it's a client-centered guiding communication style for enhancing somebody's individual, their own motivation for change. And I like to let people know that again, this is so much more than just a therapeutic modality. It is a communication style. And so after we get done with our workshop today, our 1-hour workshop, I encourage all of you to try to use the skills that we learn with your spouse, especially when he or she, is frustrated about something, hopefully external to your relationship, and just need somebody to listen and see how they respond, because the MI skills are universal in terms of communication. They really work no matter who you're talking to, no matter what kind of situation they are having. They really, the goal is just to let the person know that they're being heard and understood, and that their experience is a natural, normal experience. So go ahead and advance, please. So the first thing that's very most important about MI is that you have to have the right heart set. Just like, before you tackle any big task, you have to have the right mindset. With MI, you have to have the right heart set. And so what that means is that you really need to come into MI, into any therapeutic relationship or any sort of interpersonal relationship that you're going to use MI with. You need to come to the table with a mind and heart set for partnership, acceptance, compassion, and invocation. And so I'm just going to talk briefly about what each of those are and why they're important. So of course, partnership, one of the biggest parts of MI is it is very collaborative in nature. And so, I think it makes sense if you think about being in a helper and helpee relationship. If the helper comes to the table and has their goals up front, that might not go over very well with the person who is coming to the table for help. So you really need to come to the table with a heart set for partnership and collaboration. Also, acceptance. Everybody's experience in this world is different, and one of the biggest parts of MI is that the person who's coming to you for help is going to need to be aware that you are accepting of their experience no matter what it is, and being open to listening and open to hearing their experience. Compassion, of course. Again, everybody is coming from a different place, a different walk of life, and one of the most important topics we talk about in social work is meeting the person where they are. And what that means is that, no matter where the person's coming from, again, what their experience is, when they come to the table for help, that it's imperative that they know that they can be helped by you in a compassionate way. And then evocation. Evocation is really the process of being able to pull information from other people. And so not necessarily in a negative way, we'll talk a lot about evocation, but it is really the ability to listen and to kind of get at what the meat of what the person is kind of there for help, and to really develop that with the person. And so go ahead and advance, please. So let's talk about the basics and go ahead and go forward. Yeah. So there are 4 basic MI processes, and we're going to break it down into one by one and talk about them. But the 4 MI processes are engaging, focusing, evoking, and planning. And if you think about any interaction you might have with a client or with a patient, that these 4 processes follow along pretty close to the regular interaction that you might have anyway. So that's the good news. You're already probably doing a lot of MI, but let's talk about kind of how to hone those skills. So let's start with engaging and go ahead and go through it. So engaging is a process of welcoming the client, and you can go ahead and advance, I think 2 or maybe 3 times. There's just some, yeah, there you go. Perfect, thanks. The process of welcoming the client is engaging. And so essentially it's just when they come into the room, how are you going to go out of your way to make sure that this person feels welcomed, they feel that their presence is a positive influence on the day, on the world. And so it's letting them know that you care, showing them that you're listening, and setting the stage for change. One of, I think, the most important things about engaging is being clear with the patient about the expectations for the meeting for this day. So one of the things that's really important for me in the clinic that I work in is that women come for their primary care for this clinic, and they might have a list of 8 things that they want to address with their physician and also with me as a behavioral health clinician. But due to time constraints, we really can only focus on 1 or maybe 2 clinical, sort of aspects each day. And so when women come in and they have this list of sort of 8 things, it's really imperative that we, in an engaging manner, let them know that we can't hit all 8. And so when we're doing some engaging, it's really important to let people know that you care, but also to set the constraints and the boundaries of the meeting up front. And so go ahead and advance. The 4 basic MI skills are a huge part of engaging. And so let's talk about these 4 MI skills. So they are open-ended questions, affirmations, reflective listening, and summary. And if you see that the first letter of all of those together spells ORS, and whenever I'm teaching a new clinician or a new helper to use MI, I always encourage you to use your ORS if you get upstream. So if you get into a situation with a client or patient and you just really feel like you don't know where to go next, or you're not sure what the next step should be in helping them, get out your ORS and just use those. And so open-ended questions, these are questions that don't have a 1-word or like a yes or no answer. And so it's really anything that you can ask that person that's relevant to the situation that will get them talking. And so if somebody comes to you to talk about perhaps like their insurance benefits, and you're not sure of an answer, or you're not sure kind of where to go next with the conversation, it's absolutely okay to stop and ask, what do you know about these insurance benefits, or what are you hoping to achieve once you have benefits? Just anything that gets them sort of talking more. Again, the goal of MI is to make the person feel heard and understood, and listened to is really the big part of it. And so if you're asking them to explain more about their experience, then a lot of times that contributes to them feeling listened to and heard. Affirmations are just short positive statements that sort of let the patient know or the client know that not only are you listening and that you understand what they're saying, but that you are thinking positively about their strengths in that situation. And so affirmations can be anything like, hey, good job with that situation that you experienced, or I can tell that you have a real strength for talking to other people. Just picking out the good parts of kind of what's going on and reaffirming those to the patient or to the client. Reflective listening is imperative in motivational interviewing. And so reflective listening is a really specific skill of being able to listen to people when they're talking, and being able to reflect back to them what was said during that time, but not like a parrot, not like you would just repeat what was said during that time period, but you would repeat back and essentially try to kind of capture that person's emotional aspect. So if they're frustrated and angry telling you about a situation, you might say something like, oh, I can see that this is really upsetting for you that that you're in this situation. Reflective listening is really hard at first. I think that in our society we're sort of taught to not listen to each other necessarily. We're taught to hear each other, the words that are happening, but a lot of times, unless you're sort of trained in reflective listening, we find that as somebody's talking, we're busy thinking about what the thing is we're going to say next. And so when you're doing that, when your brain is sort of on overdrive thinking like, how do I reply to this? Then you're not actively engaging in reflective listening. And so I always encourage people to just stop, try to put what's happening in your brain in the background, and just try to listen really, really actively to the person in front of you. And then if you can reflect what you've heard or what you think the person has said, it's really helpful. One thing about reflective listening that's interesting is that people will tell you if you've gotten it wrong. And so if you say, man, it looks like you're really frustrated about this, they may say, no, I'm not frustrated, I'm downright angry, or I feel like being aggressive about this. And so it's a really great skill to have, because it's really great in the helping relationship to kind of steer the conversation and to figure out what the end goal is. And then summary. So summary is it's just really it's kind of like tying up the conversation and putting a little bow on it before you move on with the person. And so after a few bits of conversation, you might say, okay, so let me see if I have this right so far. And you can say you're here today because you're looking for insurance benefits. You're upset about the situation because you've had a negative experience, and you're hoping I can help you to find a better way through this maze of insurance benefits. And so you can kind of see that by summarizing, like I said, you kind of put a little bow on the package and hand it back to the person and say, is this right? Is this what we're looking for today? So go ahead and advance. So the next MI process is focusing. And when we're focusing, we're working with the other person to just figure out what the most important thing is to focus your time together today. So like I said, I work in primary care. I know a lot of you work in lots of different environments, maybe clinically or maybe elsewhere, but none of us have all the time in the world, essentially, right, to spend with other people. And so when we're focusing, we're just setting, again, those realistic boundaries and realistic expectations about what we can and can't accomplish in today's meeting. You're also opening the door to this person, again, to let them make the decisions about where we're going with this time and what we're working on. So kind of going back to that situation where a woman might show up to this women's clinic that I work in with 8 different, things on her list that she wants to discuss. And she may have even handed me the list, which happens a lot. And I might see the top 2 are that she can't get her diabetes medication. She can't remember to take it. And then also perhaps she's having some panic attacks. And so I might say to her, oh, it looks like these are the 2 most important things on your list. And then she might say, no, you know what, actually, since we're here today, I want to talk about this fight I had with my partner instead. And so it's really, really important that you always put the onus back on the person that you're working with to let you know how to focus the conversation. So go ahead and advance. Here are some, you can go ahead. I think there are 3 more that you can kind of advance. Yeah, there you go. So there is a technique of focusing called a quick connect. And so quick connect essentially means that you're reaching out to the person and just asking them essentially to kind of guide the conversation. And so here are 4 sort of examples of a quick connect. One of them, it seems like you're concerned about fill in the blank. Would you like to use our time today to focus on this? And then where would you like to focus our time today? I hear you saying that blank is a problem. Should we turn our attention there first? And then it sounds like you're upset about whatever it is. So go ahead and advance. So evoking motivation is the meat of MI. And it is the hardest skill to master, and it's also the most important probably skill to have with MI. So like I was saying earlier, the kind of what's part and parcel to MI is being able to let the patient know that you are listening to them and that you're understanding what they're saying, you're understanding their experience, and that you are working with them to reach a goal. Sometimes that goal is just to get the person talking about whatever it is. And so one of my clinical expertise areas is tobacco cessation, and that is a touchy area for a lot of folks to discuss. Tobacco is, it's pretty clear to most people who are using it that it's, not good for you, and that you shouldn't maybe be using it. But a lot of people have an emotional attachment to tobacco. So you have to kind of tread lightly. And so I like to use this as an example when I'm talking about evoking motivation, because most people who come in to talk about tobacco cessation are not ready to quit today. If they're ready to quit today, they probably wouldn't need me to sit in a session and talk to them about it. So essentially, evoking is kind of working with the patient to figure out where they are in their stages of change in order to get information about what kind of interventions are most appropriate at this stage. So it can, individuals' motivation can influence every second of every day. They may have made the appointment 2 days prior, and maybe they were sort of a 9 out of 10 in terms of their readiness and confidence to change. But perhaps today's a different day, and maybe they had a stressful day yesterday, and they noticed how reliant they were on their tobacco use to kind of get them through a stressful situation. So evoking motivation is something that you need to do with the patient or the client every single time you talk to them in each episode of care. So you need to kind of be sure that they still have motivation, that they're still kind of ready to work on whatever it is. And motivation can be really, really influenced by the interpersonal style of the helpers. And so, again, it's really important that we fall back on our oars, and that we come to the table with the correct heart set, like we talked about earlier, because it can be really easy to kind of lose track of what the real goal is. And I think, again, tobacco cessation is a really great example, because I think if you asked most people what the goal is of helping somebody talk about tobacco cessation, they might say, well, the goal is clearly to help them quit. Well, certainly, that would be the best case scenario. But again, some people are not ready to quit. Maybe they're there today to talk about different options for quitting, or maybe different nicotine replacement therapies. And so sort of this harkens back to the other two processes of MI that we already discussed, that it's important that the patient or the client is the one that's driving this conversation and not us, because clearly our goal would be to help everybody quit smoking if we could, or to help everybody, engage in proper nutrition and weight management procedures, or whatever it is. But sometimes that's not possible. And sometimes we have to start where the patient is. And sometimes that's just, they want to learn about what tobacco cessation means and how it works. So go ahead and advance. We'll talk more about motivation. But one thing that's really, really important about motivation to know is that ambivalence is a natural part of this process to change. And so ambivalence, I always think of someone who is ambivalent as literally sitting on a fence. And so perhaps on one side of the fence, it's sunny and there's a garden, and on the other side of the fence, maybe it's rainy, but that looks nice too. And so, again, I think tobacco cessation is a really great way to kind of describe this. And so when asking a person who wants to quit smoking, or who's maybe come to discuss tobacco cessation, what their barriers are to quitting, I almost always hear people say, well, I love smoking. I love to smoke, which to maybe somebody that has never smoked might sound strange, but as a previous smoker in a different life myself, it makes sense to me that, because, like I said, maybe on the rainy side of the fence, it's ugly over there, but then maybe you can kind of see the beauty in it too. And so sitting on the fence is a big part of it, and knowing that it is okay for your patient or client to sit on the fence for as long as they need to, until they make a decision about whatever it is that they're sort of looking to. So addressing that ambivalence is a really crucial MI skill. And there are lots of different ways you can do that. If you're going to be with us in subsequent MI trainings, the advanced trainings, we're going to talk a lot more about specifically how to address ambivalence and how to evoke really helpful change talk from people. So go ahead. So again, there's two sides of ambivalence. There are the weeds and the flowers. And so when people are talking about their goals or why they want to make this change, whatever it is, maybe I'll kind of switch to a different example. Perhaps it's nutrition and weight management. And so, I help a lot of women who maybe have been like newly diagnosed with a chronic illness or chronic sort of pain issue, and they need to change their diet in order to help alleviate some of their other conditions. And it's hard. If anybody out there has ever tried to change their your eating habits before, it can be really, really difficult, especially, if you've been doing the same thing eating wise for a really long time. So you might hear people say, and I guess I can give you a specific example. I have a patient who, again, is newly diagnosed with diabetes, doesn't really understand how to eat appropriately for that diagnosis. And I am not expert in nutrition, so I wouldn't necessarily have that chat with her. But what the talk that I was able to have with her was about her motivation for wanting to change her diet. And so the resistance talk is the talk that lets the patient kind of work through why it might be difficult for them to change. And people almost always start here when you start talking to them about MI. So they might say, yeah, I know I have to change my diet, but, and when you hear that but, that means that there's some resistance talk coming. So here comes some resistance talk for our patient who has newly diagnosed diabetes. She might say, I'm too old to change the way I've eaten. I've eaten this way my whole life. I have a whole fridge and a whole freezer full of food that's planned for my family and for myself. And I don't want to change the way I'm eating because I don't have money. And so all of those things are resistance talk. So our goal as MI clinicians or as helpers using MI is to focus on the flowers instead and to try to get to some change talk. And again, we'll talk a lot more about that in the advanced strategies, but for the basics, I think that's we can sort of leave it at that. So go ahead and advance. So let's talk about darn cat. So here are some a little bit advanced ways, not necessarily sort of down the line advanced, but just some strategies you can use as an MI helper to really get into listening to change talk. And so again, this is if we're looking for the flowers. We'll go ahead and get into some of these more advanced strategies. And so let's talk through these darn cats. So if our patient who has diabetes, is saying all these things about her, her freezer and her meal plans and the money that it might take for her to change the way that she eats, we might try to ask her questions to try to get some of these darn cats as responses. So let me kind of explain what that means. So she might be saying, I don't want to change because of X, Y, and Z. A really nice, simple question to ask to kind of get at some of these darn cats is to ask the client or the patient, hey, I hear you saying lots of reasons why it's difficult to change, and certainly it's going to be very, very difficult for you to change, but I'm just wondering why you might want to. And this will catch people off guard sometimes, but essentially what we're getting at is why are you even here? Why are we even having this discussion? Is there a glimmer of hope that you do want to change? And so she might come back with like, well, yeah, my doctor just said I have diabetes. That's a chronic condition. I don't want to die when I'm 65. And so that right there is sort of the first door that's been opened into this really great change talk. And so, so that was a reason for changing. And so you might say, why is it important for you that you live past 65? And, there are a million answers for that. Most of the time, we end up in a discussion about grandkids. So there's some desire to change there. You might say, okay, it sounds like there are lots of barriers to making big changes right now. That's totally understandable. I wonder if there's a little change we can kind of get at, maybe, is there a habit that you have that you've been thinking about for a while that you might want to change, and how can we go about changing it? This specific patient that I have in mind, once we got sort of chatting about it, she eats while she's watching TV at night, and specifically eats ice cream at night. And so was really able to say, hey, you know what? Yeah, even though I have all these things I don't want to change, I've been thinking about making that change for a long time. And so let's start there and let's make some ideas about what I can do instead. And then the CAT part, the CATs, these are a little bit more advanced also. You might not get to them in the first or even the second meeting with a person, even if they're telling you like yes, I'm motivated to change. They might not feel very, very committed to this change at first. They might not feel ready or willing to actually activate that change or to take steps. And so one thing that I think is really important as a MI clinician or MI helper is to know that, again, these are not our goals that we're working on, but these are the patients or your client's goals, and that they're driving this. And if they're not ready to commit to a change or to activate, then it has to be okay. Because if it isn't okay for you, they're going to know that, and it will complicate the therapeutic or the helper relationship. So, all right, let's go ahead and advance. So let's talk about planning. Planning is the last bit of it. And again, MI is really nice because it sort of follows maybe what you might experience anyways in your clinic or in your area of expertise. So you engage, you focus, you evoke, and then you start the planning. And so the planning has to be informed from the conversation. Again, because you might have talked for 30 minutes about tobacco cessation techniques or nutrition weight management techniques or physical activity, behavioral activation, or any number of different things. And again, as helpers, I think our goal is always to get the person healthy. And so we need to make sure that they're driving this planning part also. Perhaps we've talked for a long time about, again, tobacco cessation, and the patient has said, like, yes, I totally want to quit. I feel there. I feel really committed. I feel able to take steps. And then when you get to the planning phase, they absolutely take a huge step backwards, which happens a lot because maybe they got some momentum, they got some motivation. And then when it comes to like, okay, well, when is your last day smoking? That might be a little bit much for them. And so when it comes to planning, I again encourage you to use those ORs again, those open-ended questionings, those affirmations, reflective listening, and summaries. So you can say, okay, we've had this great discussion about tobacco cessation. Seems like you've gotten some motivation going. Where do you want to start? What do you want the next step to be? And let the patient make their own kind of decisions about where to go from here. So go ahead. So when it comes to making SMART goals, we have to think about our SMART goals when we're creating a change plan. And I know SMART goals are something that we talk about a lot in a lot of different ways. And I think that they're very, very relevant to motivational interviewing because it has to get very, very specific, measurable, achievable, realistic, and timely. All those things are very important when we're coming to making decisions about helping people achieve these big life goals, essentially, right? So even, our patient who has newly diagnosed diabetes, she wasn't ready to make a big goal about, changing an overhaul of her nutritional aspect of her life, but she was able to make some really specific goals in terms of not eating ice cream. And so again, we have to get really, really specific with it. So is it eating at night that we're targeting, or is it eating ice cream at night? And for her, it was actually just eating at night that she wanted to really tamp down on. It has to be something that's measurable. And so I really, really encourage you, when it comes to measurable, get very specifically measured. So it's really easy to kind of say, oh, within the next 2 weeks, I'll stop eating, at night while I'm watching TV. But you might say, it might be easier to get even more measured than that. And you might say, I will not eat after 7:00 p.m. Monday through Thursday, 8:00 p.m. on the weekends. Or maybe I'll eat a specific calorie amount past dinner, or maybe that the measurement is that I won't eat anything at all as long as the TV is on. I have to be mindful about my intake. But getting really, really specific with it is so much more helpful for people to have a guide in terms of like achieving their goals. It has to be something achievable. This one is huge. So one thing I learned doing lots and lots of tobacco cessation work is that people, again, and I think that people who use tobacco know that it's not great for you. And so they want to come across as ready to quit, and they feel ready to quit. And especially if they're talking about it, maybe, they're finding the conversation motivating. And so a lot of times we'll get to setting the goal and a person will say, I'm going to quit tomorrow. For a lot of people, that's just not achievable, especially if they're, using half a pack or a pack of cigarettes a day. There's a reason why that's happening for those people. And so making sure that the goal is achievable is really, really important. And it's okay to say to the person, oh man, that's a huge goal, and I admire you for wanting to sort of tackle it, but I'm wondering if there's a better way, or if there's something that we know you can achieve that we can start with. What happens a lot of times is if the goal is not achievable, the person will disappear. They'll never come back. They don't want to talk to you about what they feel is a failure. And they might feel like it's a failure themselves and stop trying to make really positive behavioral health changes in their lives. So being sure, and for the first goal, again, say you're trying to help somebody quit smoking. If they smoke, maybe 10 cigarettes a day, we might make the first goal incredibly achievable so that they experience a sense of success. And a lot of times success ends up being sort of like a snowball, like a positive trajectory snowball, where people feel really good about their first success, and then they want to tackle the next one, and they want to tackle the next one. And so, for somebody who smokes a half pack a day, we might start with, let's eliminate one cigarette today for this week, and then we'll come back together next week and talk about how that went and talk about what we can do from here. So that's really important for it to be achievable. It also has to be realistic. And so, if somebody is interested in starting an exercise program and they want to lose 5 pounds in 1 week, well, again, we have to be sure that it is realistic. And this is another space where we can sort of educate and help guide our clients into a space where they can, again, be very successful. So letting them know, 5 pounds in the first week is not achievable for every person. Let's be more realistic in our expectations. And then timely. So it has to be something that we can institute now. A lot of people who I help with tobacco cessation aren't ready, again, to make those steps into quitting smoking today. But what they maybe are ready to do today is to start tracking their use. Maybe they can use a pack tracker and write down the times where they're using cigarettes or their tobacco. And then we can come back and have a discussion about patterns. We can have a discussion about what the function of each cigarette is. And we can have, a discussion about how to sort of mitigate for those things. So it has to be timely also. Go ahead and advance. So let's talk about the stages of change, because again, when we're going through the process of helping somebody through an MI lens, it's imperative that we figure out where they are in terms of stages of change, because the MI intervention is going to differ based on what stage of change that they're in. So let's go ahead and walk through these together. So the first one's pre-contemplative. And this is a person who is not considering change. This is an ignorance is bliss kind of person. And so someone who's pre-contemplative about tobacco cessation might say something like, my wife said I had to come here today, or my doctor said I had to come here, and that if I didn't come and talk to you about tobacco cessation, that I would be sleeping on the floor tonight or on the couch. But it's for pre-contemplative, they are coming to you for help, but they're maybe not ready to jump in any way, shape, or form. And so the intervention, a lot of times the MI intervention for this is to let people know that it's okay for them to be in pre-contemplation, that it's a natural part of the change process, the change process, and that that they can certainly work their way up with you. And if they ever get to the point where they're contemplative and not pre-contemplative, that your door's open to them. A lot of times MI interventions that come along with pre-contemplative are things like giving people information, or setting an appointment with them for 6 months in the future, if they want to come back and maybe chat then about what it would be like to quit smoking. So pre-contemplative is difficult, and a lot of times people who come to see you who are pre-contemplative are not happy about doing so. So just letting them know that you're okay with the fact that they're pre-contemplative makes a huge difference for these folks usually. Go ahead. Yep. Contemplative is next. You're almost exclusively going to see folks who are contemplative. And so being contemplative, exactly what it sounds like. These people are contemplating or thinking through that perhaps they might want to make a change. So they're ambivalent about that change. They're kind of sitting on the fence. They're not really considering a huge change within the next month. And so again, this is our patient who just got diagnosed with diabetes and is telling me all those reasons why she doesn't want to quit. Doesn't want to change her eating patterns. But when we explored a little bit more with her and we were able to kind of evoke some of that really helpful change talk, there were really good reasons why she wanted to make changes. She just didn't really know which changes felt doable to her and which changes felt doable in the next month, essentially. So people who are contemplative, again, you're going to see by far and large that these are the biggest group of people who are going to come to you. And they might say, their opening is usually something like, I want to fill in the blank, but, and then there's a bunch of fill in the blanks. So I want to take care of my diabetes, but I don't want to change the way I eat right now. Or I want to lose weight, but I don't want to, I don't want you to tell me that I have to run 6 miles a day on the treadmill in the gym. And so contemplative folks are great because these people can usually open a door or window for you to come in as the sort of the change talk helper, and open a space for you to start discussing those change talk options. So again, look at those darn cats when you're working with someone who's contemplative. Open the change talk using your oars. And if you find that somebody closes down when they're in contemplation and you're talking with them, then I encourage you as the helper to stop sort of your line of discussion, whatever it is, and kind of pull back a little bit and see if maybe they're feeling a little bit defensive. But some of these folks also kind of talk themselves into pre-contemplation, and that's okay too. So the next bit, preparation. You will see some folks in preparation, and when you get these people in, they're so fun to work with because they're not saying, I want to quit, or I want to change, but what they're saying is, I am ready to change. I don't know how to do it. And so, then all of our training comes into effect, all of our ability to help people make these really positive health behavior changes, just sort of is easy to kind of flow. And so this, what this might sound like is somebody who's coming in and saying, I'm ready to quit smoking, but I don't know how to do it. And then my intervention is to educate them on the nicotine replacement therapies or the medications that are available, or, to talk to them a lot about setting those SMART goals. When is the time? How are you going to do it? What factors are you going to put into place to help you in a tough moment, that kind of thing. So they're really just kind of testing the waters. They're planning to do something, planning to make a change within the next month. It's also really, I think, important to point out that clients might be in preparation for one change and pre-contemplation for another. Again, and so our patient who's just newly diagnosed with diabetes is a great example. So she was in preparation about the night eating, but she was in pre-contemplation about, starting to track her food, or thinking about macros, or thinking about, exercise, those kind of things. So if you're working with somebody who isn't able to identify a change that they want to make that's adjacent to whatever the change is that they are supposed to be they're talking to you about, sometimes it's okay to say, well, what are you prepared to work on? What is a change in your life that you want to make? And most people can identify at least one. I spent a lot of my career working with adolescents, and their parents would just sort of drop them off, at times for therapy. And they would say, I'm not, my parents want me to hang out with different people or get good grades, or, whatever the change was, but I'm not interested in doing those things. And having a frank discussion with them about, okay, so what are you prepared to do? What kind of changes are you prepared to make? Was super helpful, because they might say, I want to learn how to play the guitar. And so that's something that I'm willing to work on, or I want to get a job, or I want to learn how to talk to, other peers, or whatever it is. So, say you're in a clinic and you're working with someone who's been referred to you for tobacco cessation, and they're just sort of not into tobacco cessation. Maybe they're open to talking about starting a walking program, or maybe they're open to talking about engaging in some financial wellness, or something to that degree. So when you have people who are in preparation, they're fun to work with, and then they'll move to the action phase. And when you come to action, generally you don't see these folks, which is great and wonderful. In the clinic that I work in, again, it's primary care. And so I'll see women coming through the clinic for everything else that you might come to your primary care for, aside from behavioral health. And they might pull me over and say, oh, things are going great. I feel so much better, and I implemented these techniques, and now I feel things are great. So I'm kind of lucky in that regard, I think, because of the clinic that I work in. But in places I've worked before, you don't see people who are in action because they're doing it. And action, when people get there and they really get their stride, it feels great for them. It feels awesome. Other people notice the changes that they're making a lot of the time. If somebody's, say losing weight, or has started to stop smoking, people around them might say like, hey, I noticed that there's no, tobacco scent when you're walking through the office anymore. Are you quitting smoking? And then a lot of people have a lot of positive regard for people who are making these like really healthy behavioral changes. And so if somebody's losing weight, people might notice that they look different and, comment on that. Or, if somebody started a physical activity program, they might notice that it's easier for them to reach their goals, or that they're running easier, or they're breathing easier, or whatever it is. So action looks and feels pretty good for a lot of people. And by and large, they do not need support, because people in action have figured out how to do it. And they're sort of reaping those natural benefits along with their change. So the last one is maintenance. Maintenance is really, really hard. It's a lot harder than it might look. When people are in maintenance, they have come to a spot where they have made the change. Maybe they've lost all the weight that's appropriate for them to lose. Maybe they've completely quit smoking for 6 months. Maybe they've come to a place where they can run the 3 miles that was their goal. They've reached their goal. But it's really, really hard to stay there. You don't get the natural positive benefits of people saying, hey, you look so different, or hey, I noticed you don't smoke anymore. That's so great. Sort of nobody's around to give those pats on the back. And so you have to maintain that inherent motivation throughout, which is so, so difficult. And so you will see lots of people in maintenance who are kind of coming back around, who are having trouble maybe maintaining that maintenance, and just sort of want to have some information from you about how to maintain that motivation. And so you'll find that people who are in maintenance, the best motivational interviewing intervention that you can use with them is to go back to having those discussions about ambivalence. And so they might say, I've been at my goal weight for, 8 months now, and I'm just feeling really kind of low about it. And I miss eating ice cream at night, and I miss, X, Y, and Z. And so you might find that the most helpful intervention is to kind of bring out those darn cats again and kind of get some good change talk around why they're still interested in having this change happen. Okay, go ahead. So moving to action, now that we know what the stage of change our patient's in, and now that we have some good ideas about how to use motivational interviewing techniques, how do we use motivational interviewing to move people to action? So go ahead. Why don't people want to change? Well, go ahead to the next slide. Change is hard. It's so hard. We get into these patterns of behavior, or sometimes they're learned. Sometimes they have to do with our natural, hormonal fluctuations. Sometimes they have to do with all sorts of other things that are going on in our life. And so change is very, very difficult. And one really great MI technique that you can use to work with people who are having some difficulty changing is to talk to them about what barriers they may experience. So when I was doing a lot of tobacco cessation work external to the clinic that I work in, one of the things that happened over and over again is that people would tell me, that they're very, very ready to make this change. They feel it's very important. They feel confident that they can quit smoking, but perhaps they might live with a partner who smokes. And so that's really, really difficult to make a change when the behavior is shared within your household. So that's one reason why change might be hard. But it's just exploring the barriers to people. Some people might say, I really want to start running, but I don't have money for, $150 pair of new tennis shoes. And so the intervention might be helping them find a place to get shoes that isn't, that aren't an arm and a leg. So change is just, it's really hard for people. There are lots of barriers, and having a frank discussion about what they might experience in terms of barriers can just be really helpful for motivational interviewing. So go ahead. One really, really helpful motivational interviewing intervention that I love and I use all the time in my clinic is exploring values. So essentially, when we talk about values, they're just sort of the principles or guides. They're things that they're sort of like our guiding stars in a lot of ways. And there are, 500 different values that are, we're sort of able to kind of work with. If you go to the motivational interviewing website, which I believe is just motivationalinterviewing.com, that website is started and is supported by the folks it's Miller and Rolnick, who are the men who started motivational interviewing. One of the tools that's available on there is what's called a values card sort. And I definitely encourage you to go ahead and print them off, cut out those cards, laminate them if you can, and use them with your clients or with your patients, because essentially what it is this, I think there's about 200 cards, and they all have a different value on them. And they're everything from like wealth and beauty to affection to purpose to any sort of value word you can think of. And what the patient or the client, and I encourage you to do it too as a helper, just to kind of get a sense of where you're coming from. The goal is to narrow it from 200 values down to 10. That's the initial goal. And so there are cards in the values card sort. One says very important to me, one says important to me, and one says not important to me. And so essentially what you do is make 3 piles to start off with and put the different values in the piles. You get rid of the important to me and the not important to me piles and just focus on the very important to me. Try to narrow those guys down to 10. It's hard to do. And once you have it narrowed down to 10, then narrow it down to 5, and then take a deep breath and narrow it down to 2 different values. And so a lot of times we find that when we see our list of 10, it's very illuminating for us in terms of maybe why some of our behavior is the way that it is. So a good example, I guess I can share with you from my own life. I like to do this for myself at least once a year. And I was experiencing just sort of a lack of social interaction after I had a child, which is, par for the course. But when you're a new mom, you might not know that. And so when I did my values card sort, friendship just wasn't even in the top 10 because I was just so focused on having a new child and what that was like to be a mom and those kind of things. And so when I saw that it wasn't in my top 10, I thought, oh, well, I'm not, this is not part of my top values right now. And I'm not doing anything to sort of work on that right now. So, so that's just an example, but it's really fun to do the values. It's really fun to explore values with patients. When we use motivational interviewing along with a values exploration, it can be really, really helpful. So I was working with a patient who wanted to quit smoking, but they worked in a situation where everybody that they worked with also smoked. And so this was their break time. They didn't want to miss out on the gossip. They didn't want to miss out on, the friendship. And so it was really, really difficult for them to, sort of make the leap to quit. But then we started to explore this person's values. Family came up as in their top 2. And so we were able to kind of discuss their values around family and how that comes back to them quitting smoking and what that might be like for them. If they smoked until they were 75 and died early, and what they might miss out on in terms of their family. And so, again, it's just really illuminating, a really great tool to use for MI. Go ahead. So we will talk more about these rulers when we come to the more advanced MI in subsequent sessions, but this is really great rulers to determine readiness. You can ask folks on a scale of 0 to 10, how important is this change for you? And then on a scale of 0 to 10, how confident are you can make this change? So for the how important ruler, if they say, oh, it's a 10, and then they say, oh, but I'm a 2 for confidence, that definitely warrants a discussion about why maybe they're not feeling so confident. And perhaps it is something like I just discussed. So maybe all my coworkers smoke and I don't want to miss out on smoke breaks and I don't want to miss out on all the gossip. So this is a really great tool to have. And again, we'll talk a lot more about this in subsequent sessions. So go ahead to the next slide. Yeah, so if somebody says a 6 for important and a 3 for confident, again, that sort of warrants some discussion. So I wanted to leave just a couple minutes. If anybody has any questions, maybe you can go ahead and just type them into the box. And I'm not sure, Elsa or Amy, if you can sort of moderate those. But I would love to answer any questions if anybody's got some.
Yes, please type any questions in the chat. You're also welcome to take yourself off mute at this time as well, if it'd be easier to ask your question verbally.
Yeah. For those of you that are phone only, it's *6 on the telephone for mute.
And while we're giving people a chance to type in their questions, I'm also going to put the link of the evaluation of today's webinar in there as well. We'll be sending out the slides and a link to the evaluation following this call. And so we'd really appreciate if you could complete that evaluation. And then also just to let you know, so the advanced MI workshops are being offered through the Alliance. And so CCSP has sent out information about those webinars or workshops. And so we will send out that information again.
I'm also happy to answer questions over email if anybody wants to just email me directly.
Okay, we will share Rebecca's email address as well with you all. It doesn't look like we have any questions yet, so I'll give us just one more minute, think of anything, and I am putting the link to the evaluation in the chat as well if you have 1 or 2 minutes to complete that. All right, so big thanks to Rebecca. I hope everyone has a great rest of their afternoon.
Thanks all for coming and joining me today.
Thank you.